Good afternoon. And so today again we'll be resuming our AI series. Today we have two speakers. Today's discussion will center around AI and cardiology, and the first speaker we have is no other than Dr. Narasimhan. I think he is one of the most revered and globally renowned electrophysiologists. But the beauty is that he doesn't think only of cardiology. He has the in-depth knowledge of life systems as a whole. So we'll listen to some of his perspectives on the applications of AI in cardiology space. After that, the second speaker is Dr. Nagarajan Ganapathi from IIT Hyderabad. He is from the Department of Biomedical Engineering, a PhD, and has worked extensively in AI and ML in cardiological applications and pain. So, sir, can I request you?
Thank you very much, Dhruv. It's indeed a pleasure, and I'm going to be talking about some of my perspectives on AI and cardiology. But it's really an exciting era for all of us because I think the potential is huge in terms of technology which can be harnessed into medicine. And we'll see that there's tremendous ramifications of this technology. In brief, I think we have seen this in telemedicine, in the era of wellness and lifestyle management, disease management in terms of hypertension, diabetes, constant feedback to patients, in terms of collating medical records and connecting the dots, some causality of disease. For example, if a person has an exposure to a heavy metal, how does it come? You have 10,000 patients being exposed, the particular disease pattern emerges. So that's going to be a tremendous advance in terms of AI, which can connect the dots better, and for which we need huge amount of data, and the machine learning will help us to further our knowledge about disease and the causality of disease. And similarly, some of these things, we were looking at novel ways of treating a particular disease. And AI will help us to look at candidate drugs which will be helpful in treating diseases much more effectively. And similarly, we realize that not all of us respond in the same way. So, personalized medicine and precision medicine will be another aspect of AI which will help us to manage our patients better. Increasingly, the disease diagnosis and management has moved away from the hospital to the patient's bedside. And that's where there is a tremendous scope for wearables and devices which the patients wear and they get discharged home. You can continuously monitor the patients in terms of his cardiac status, respiratory status by having very small implantable sensors on the patient's bed itself, on the mattress will sense how the movement happens, the pulse, blood pressure, everything can be sensed from there. So, in terms of AI, I'm just going to have a broad perspective, and then when Dr. Ganapathi talks to it in terms of specifics, we'll discuss this. There'll be an increasing role of AI in medical education because, for example, if I have a class of 100 people and then I talk, from the facial expression, you can understand who has understood and who has not. Some of the professors will pull up a person just by looking at the class and say, who has probably not understood the concept. But there are very sensitive facial recognition each of us subconsciously make, and that can be picked up by AI to tell. And if a person hasn't understood a concept better, then AI will be able to hone down on those kind of specifics. And one of the important thing is integrated healthcare. Because in modern day medicine, for example, we look at diseases as, say, cardiologists or rheumatologists or a nephrologist. But it's a system biology. For example, I'll give you an example. When I develop a toothache and a lot of my tooth become diseased and painful, naturally I will start choosing very soft diet to eat. I will start cutting down on fiber. the implication will be seen 6 months down the line. My blood sugars will rise, cholesterol will rise, triglycerides will rise. So what starts as a dental problem has implications in other organ systems. And your microbiome changes because the type of food that you take has changed. So AI will be able to connect these dots very well if you have a huge amount of data. And most important is reduction of risk, because as physicians, we try to treat a person once he has a disease. There is no incentive to understand who's likely to develop a serious problem and prevent a disease. So if you have 10,000 patients, for example, Deloitte, Microsoft, 40-year-olds, out of which there will be about 100 or 200 people who will have coronary events, who will have strokes. But the day before, there are biological signatures which these patients will exhibit. Either there is a slight increase in their diastolic blood pressure, narrowing of pulse pressure, which will portend that this patient is going to have an event. And this is a huge implication on preventing serious cardiovascular events. I cannot overemphasize the importance of AI in terms of diagnosis, because it is pattern recognition, just like pathologists looking at the slide again and again. Chromatin, this nuclear cytoplasm increases. All these things are pattern recognition. Repeatedly, it's kind of forwarded into the machine learning model. Then you will have the computers making at least a broad diagnosis as this is a normal slide, this is an abnormal slide, which needs further input from a pathologist. Same way, if you look at the ultrasound, what is it the sonographer sees? He sees a slightly different change in architecture or the density that he sees on the ultrasound and classifies this as fatty liver. Now, for the naked eye, it has to be a particular threshold by which you pick up. But an AI can pick it up much earlier than this and can prognosticate much better. The same thing applies in whether it's echocardiography. For example, the myocardial architecture changes when there's myocardial edema. As of now, there are no sensitive ways of picking it up. A very early onset of a child suffers a flu, sore throat, and then develops a little bit of a myocardial edema as a part of myocarditis. We wait for an event to occur and then pick up myocarditis when the child presents with an arrhythmia or heart failure. Whereas this can be picked up much earlier by an AI. So what I'm trying to say is AI is here for it to stay. And we need to work very closely with the persons who are working in this space, because the clinical input has to come from the clinician. Where is the relevance? And similarly, prognosis. For example, you have persons with coronary artery disease. One of them has been diagnosed to have coronary artery disease or even a cancer, and he has survived for 35 years. There is another one who has a very rapid decline with recurrent vascular events, becomes a vegetable at the end of 1 year, connected to a. So you can prognosticate which patient is likely to worsen and who is likely to have a better outcome. Similarly, treatment is going to be more and more refined. For example, all of us are aware of hundreds of procedures in medical history. For example, I don't know how many of you know, there's a very famous surgery done for coronary artery disease, where the surgeons used to take a lima, anterior descending artery, and then anastomose. And that used to be the standard of care for coronary artery disease for 10, 20, 30 years. Till such time, some brilliant scientists looked at it and said, it doesn't make a difference to the patient. The patient feels pain-free because you cut away the nerves, but the event rates are the same. So there are several interventions which are low-value interventions, which we do, but there are some high-value interventions which have really a good impact on patient management. So treatment will become more and more refined. For example, if you look at some of the biologicals, most of the greatest inventions in science which have altered the needle in terms of survival have come from basic understanding of biology. There's Akiro Indo was one of the basic scientists. He was basically working on alcohol, and how fermentation happens and then leads on to fermentation and beer. He goes and he gets interested in cholesterol synthesis and goes and looks at a grotesque surgery of doing a carotid and removing the plaques from the carotid artery. And then he goes back to the lab and say, what is the reason why they develop? And then he takes egg yolk as a model and interferes with the cholesterol synthesis. And then you have millions of people who have benefited from a simple drug called statin. So that has moved the needle in several ways. This AI will help because several years, instead of an individual painstakingly, he searched and cultured almost 60,000 egg yolks with different fungal species to come up with a statin. This may be readily available by looking at homology of certain regions and tell you what is a candidate that you should look and interfere. Your treatment is going to be much faster. For example, COVID, we saw a vaccine development happening within about 24 months, which has never been seen in the history of vaccines. And this is going to be further truncated with the advent of AI. So, and similarly, training in medical thing has been very painful and a long, distraught affair that we had. We had to go through a long-standing training, standing, holding the retractors in the operating room or scrubbing up with senior interventionalists. But this is going to be more and more moved out of the cath lab and operating room. Patients practice, I mean, the models will be available already. I think Subodh has been doing this. 3D AI-based training is available till such time the person perfects the technique. And similarly, precision medicine is going to be an important because you do know when a diabetic comes, one person responds to metformin, the other one doesn't respond to metformin. A priori, if you know that this is a candidate who will have a better outcome with a particular drug and less chance of side effect, your choice of drug therapy will become much easier. And instead of doing a trial and error method. Delivery of healthcare, for example, if you have, you know the story of Ebola. When Ebola happened, it's a serious health risk for a person to go into a village where there's an Ebola outbreak. So if you have these kind of delivery models where you can send them there by drones, collect the sample and come back, this is very realistic. So it is possible already this is happening in certain areas, but it's going to, for example, when there's a nuclear catastrophe, no one can enter a place where there's a nuclear hazardous spill. And there are drones which can go safely deliver people out of this place. And most important is outcomes research. Because in modern day medicine, a lot of what we believe is true is not true. Because several of this thing is biased by several other biases that the clinicians bias, the industry bias, funding bias. So all of them cloud the judgment of what really works. And the outcomes research will be, because if you look at patients from coast to coast, whether it's Japan, Arctic, Antarctic, a particular simple drug has shown an efficacy that will throw as a pattern and for you to cone down and pick up what is the right treatment for a particular disease. So as of now, what happens if you have an event that is sensed and then there is a reason and it adapts to a particular, the sensors give you the data points and there are several algorithms. For example, if EF is below 35%, the patient is going to die. In this person, an added element of ECG abnormality will increase the risk. So you teach, that's called supervised learning. You know from the existing facts to put out and say that these are the variables which are associated with a higher risk. And then feed in a lot of data and the machine learning will kind of say, no, there are additional factors over and above what you thought is right. These are subtle factors which predict risk. And that is where machine learning becomes important. And then like a human brain, the neuronal networks work. Say, for example, I try a therapy, it doesn't work, a particular therapy works. These are feedback loops. So cognitively, I have a thing that this thing works. Similarly, the machine itself will say, look, I have given a particular drug, the person either developed a side effect or the blood sugar didn't come, it will truncate there and move on to the next. So these kind of nodal points and things will improve with deep learning. And this is possible only when you have millions of data points to happen. So, for example, asymptomatic LV dysfunction. Asymptomatic LV dysfunction is known to be associated with sudden cardiac death. It increases the risk of death fourfold. But in a population, you can't go around doing an echocardiogram on every person, millions of people from Kanyakumari to Kashmir, all around. It's impossible. Whereas ECG, all that you need is a much simpler device. So Mayo Clinic group, Peter Friedman and group got together and see, can we extract more information from a simple, inexpensive ECG? And that's what they tried to do, because ECG is an electrical signal that is generated from myocardium. And if the myocardium is absent, definitely there should be an electrical signature proportionate to the amount of myocardial cell loss. And that is the reasoning. And they came up with ECG as a predictor of simple ECG. As a predictor, can I predict the person's contractile function? And when they had this Peter Friedman's famous paper in Nature, which looked at over about 6 million patients, ECG and echo data points, and they came up with a fantastic prediction model from simple electrocardiogram. Electrocardiogram predicted the event rates of death as well as the ejection fraction without doing an echo. So there was only one person where the ECG taken predicted that this patient is going to die within 1 or 2 years. But the patient at the end of 10 years, he was alive. And then when they pulled out that patient and then said that patient had undergone a heart transplant. So that's how he survived the next 10 years. So it was one exceptional thing, but it was highly predictive of what was happening. Similarly, we all know that atrial fibrillation, silent atrial fibrillation in elderly, strongly predicts the risk of stroke in patients with diabetes and hypertension. They are confined to, they become aphasic, they can't speak, they're confined to bed. Lot of heroic therapies that we do later on we can address probably 10, not even 1% of the population. If I can foresee this event by a simple watch that the patient is wearing, and this is what the Apple Watch study said, that you can reliably predict the onset of atrial fibrillation even before an event happens. So if that is true, you can reliably predict an event and start this patient on appropriate therapy before an event happens. So smartwatches have been used for continuous monitoring. Now they are becoming several fold improvement has happened. There's something called Lorentz plot, which looks at how the clustering of these events happen. Is it a PAC, PVC, or is it a flutter fibrillation? They can predict just by wearing a smartwatch and predicting an event to close to about 84% positive predictive value is there with this particular simple device. So this is a person with recurrent palpitations, and you can not only see how often these episodes are happen and the burden of these events. Why is this important? Because the longer the person is in irregular heart rhythm, the higher the event rate in terms of patients developing a thrombus or developing a stroke or coming to hospital with heart failure. Now I'm going to move one step upwards. This thing called upstream events. We all see a patient who comes to the casualty with acute clutching chest pain or coming with fluttering of the chest and heart rhythm abnormality. So there is something else that has triggered an event a day before for this person. What happens? The blood pressure rises, the blood becomes a little thicker, the velocity, shear force increases, all driven by some biological factors. This happens 24 to 48 hours prior to this event. And very often, the event seems something that happens limbic system, amygdala, cortex, and then this comes downstream through the thoracolumbar outflow in terms of sympathetic outflow, cardiac ganglia, from stellate ganglia, directly there is a pocket of, say, unlike a noradrenaline that is released from your adrenal gland, if the nerve directly innervates the heart and releases 2000 picograms of NORAD in one go, the heart will start fibrillating. And that is what happens with emotions. And that is clearly exemplified by a condition called stress cardiomyopathy. Women, postmenopausal group, when they have a very tragic event in the family, the heart almost squeezes to death because of sympathetic storm. It develops a constriction. They come with severe heart failure, or they sometimes succumb to heart failure and die. And one of the extreme examples is the vessel going into severe spasm, closing, throttling itself, developing a clot. And this event nowadays can be predicted by AI 1 or 2 days before. Probably, I think Dr. Ganapathi is working on this already. I'll ask him to talk about how transcutaneous signals predict these events 1 or 2 days before the event happens. So, as I said, when you see an unpleasant event or a very troublesome event which provokes a bout of anger or severe depression, there is a catecholamine storm which is very asymmetric. So, if you measure the serum catecholamine levels, it may not be predictive because these are aliquots of noradrenaline which are directly released by ganglia at the nerve endings. They may not be predictably seen by looking at the sampling the peripheral blood. And a physician in US started several years ago working on just, see, all of us communicate, these are biological signals. For example, at a particular frequency, the signals in the heart travel. Suppose I set a frequency between 30 and 100 hertz, I'll selectively pick up the cardiac signals. At a different frequency, the brain communicates. The EEG's filter setting is different. So, and that is how the biological systems communicate, and they can be very well picked up by using 2-3 sensors and changing the frequency. You can pick up several of these biological signals at the same time. So, ECG to predict future AF, ECG to predict sudden cardiac death is already validated. It is there in a vast majority of persons. In fact, the Chinese group looked at the facial expression of a person. Suppose 5 of us are sitting in the clinic. You have a camera, and the camera can predict by looking at the facial expression who's likely to have an atrial fibrillation versus who's not. It's validated and it's published. So understanding that, but having said all these things, the clinical context is important because you can't do these things in isolation. That is why the clinical context becomes very relevant. I think AI is going to be a tremendous boon for physicians if we try to harness the technology and take it forward in terms of screening for arrhythmia, screening for sudden cardiac death, screening for future coronary events. All these things can be picked up. Similarly, there are several AI algorithms which are already available in terms of predicting the coronary artery disease and improving the safety of this. There's automatic release mechanisms are now available where the machine releases the devices within the heart. If you set the anatomical landmarks, you say this is the landmark where I want the device to be released. It automatically releases it and it can recapture it. These are still at experimental stage, but sooner or later it's going to come as a reality. So similarly, any of these physiological perturbations can be picked up very early on when you have AI added into your tool. And that is going to be significantly better in terms of disease prediction, prognostication, and even when you do procedures. For example, if you know that there is a soft block which is prone to dissection, and the wire tip is seen and the wire reaches there, it can give you a warning signal. For example, when we move a catheter, the catheter tip has a sensor, and anything more than 30 grams per square centimeter increases the risk of perforation. So there are now sensors available at the tip of the guide wires, at the tip of a catheter. When the operator increases doesn't have a good tactile sense, and it can give you feedback. We get in EP lab, we get a red alert saying that the contact force is increasing. This is the kind of quantum change in terms of safety and efficacy of these procedures. Similarly, you have a lot of holographic display of vascular structures for you to safely navigate. This is what I meant. There are anatomical landmarks. You can fix the landmark and put two anatomical tags here and tell the machine to release it at a particular place at a particular speed, and that is predictably doing. More importantly, in cardiovascular genetics, all of you know the tremendous advances that have come in terms of PCSK9 inhibition. Was a single clinician who was, people would have thought he's a joker writing some vague observation. There's a French cardiologist who noticed that in a subset of person, a PCSK9 kindred of family had this PCSK9 deficiency, and then they have coronary events. And that single event led on to a sea change in our paradigm shift in our understanding as well as therapeutics of coronary artery disease. We are sooner or later seeing coronary artery plaque regression that is happening with some of the molecules, which can be used once in 6 months as a vaccine. And the half life is so long, it can be given once in 6 months. So, those are, as I said before, human mind, we think of only so many things. For example, base polymorphism is very strongly associated with sudden unpredictable cardiovascular risk. We never used to think about it. But machine learning and artificial intelligence, they pointed out that the odds of these events are happening much higher by looking at this data set available from the patients. So what Dr. Sashikala is doing now, as well as Dr. G.V. Rao and Dr. Reddy has put together, the biobank that you have, if you have a clinical data set which marries into the biobank, you can predict events over a period of time. You would have done yourself a great favor in predicting who is going to be at risk of breast cancer, whether there are early warning signals, these things can be picked up. I just gave a bird's eye view of what is happening and what are the potentials that are available with AI coming into fore. And we are really excited to hear Dr. Ganapathi, who is already working on these areas. Welcome, Dr. Ganapathi. He'll take it further. Thank you.
I was preparing on the slide and the date. Sorry, yeah, it doesn't require. Yeah. So what I will be present today, is a little bit nervous because now I'm going to talk with a about AI and talking in terms of biomedical. So let me pardon me if in case I'm going somewhere wrong, just correct me on that part. So what I'm going to do today is like I'm going to talk about technology advances in the sense. I'll be talking about different variables, devices which we use in our lab, and somehow we are trying to transform spaces into diagnostic spaces, and that's what when I came earlier, I was just highlighting it. So one thing which I found or I felt it in during our last interaction, or to most of the meetings or smaller group discussions I go and no, like whenever I go there, I introduce myself like I was working on AI and machine learning, and the usage of AI and machine learning for me is more from a clinical perspective. So most if you have people who are working on AI and machine learning from a computer science perspective, those there are people who use AI and ML, but they say that we are working on AI ML, but they're using it as a tool for application.
For me, AI and ML with clinical perspective is what I look into, and that's where I myself distinguish from a regular computer science or an electrical engineer who is working on AI and machine learning. For me, context is more important. It's not just the ECG events or ECG signals which is just coming out. It's more about more what happened at that time, and because of that, what the signal was. So that's what is the focus. So one thing which I always found myself in a critical scenario is like when I go in these group discussions is can you do something on AI ML with some data? And I can do many things on AI ML with some data, but what is the requirement? Yeah, and that exactly is the question. And then that because most of the time there is kind of a lag in terms of so much of advancement which is being communicated via mobile phones, Facebooks, Google search papers that AI can do anything. But to be very frank, AI cannot do everything. And for AI to do many things, you require human interaction, human intuition. And that's where what I thought of is like I will just take you to a little background of what is an AI ML is a very very small general intro which you can always look into in Google and you can search it down, you can get it. It's just a 10-15 minute slides where I try to explain you what is AI, what is AI ML is, when you require AI ML is, and how AI ML becomes so popular. Because I'm sure before 5 years also, hospitals were running, clinicians were there, disease diagnosis were happening, and now there was little advancement. And what that advancement is, we will be talking about that, and then from there I will take it to physiological sensing, what will be, what the scenarios are being, and what we are doing in our labs now. So we'll be talking on that part, yeah. So I will be talking about brief of AI, then physiological sensing, what's going on, wearable technology, what is the current trend going on. We'll be talking about something new which is popping up in the current biomedical engineering called as ambient intelligence. So I will be explaining that also. Then my like soul of work, which is smart private spaces, transforming spaces into diagnostic space. So I'll be talking on that. And then I will show you some of my work which uses AI ML for clinical applications and how they are being and what they are being doing. So in traditional programming, what we use is like we use data, we use program, and we feed it to a machine. And what we expect is an output. And this is what is being a regular system. Yeah. Even in a control system also, you have an input, you have a set of rules which you feed it to a machine, and you know this is what is an expectation of output. With AI ML, it is a little different where you tell the output also. You give input, you give output, and now you're telling to the machine, come out with a program which, which can bring you this output based on the input. And this is kind of a machine learning aspect. If you can look into the naming itself, earlier one is the traditional programming or traditional learning. The current one here, we are trying to make machine to learn. So we are giving input, we are giving the output. What we are giving, what we are asking from the machine is program, from which you can come out with this output. So if output gone, the whole system gone. So that's where we call it as a supervised learning. Where the learning is happening, machine is coming out with a program for a given input, we are telling what is the output. And that output is what we call it as annotations, labels, ground truth. Yeah. So for example, task where machine learning is very very popular is like recognizing some patterns. Yeah. In this case, I have given like facial expressions. You are looking into handwritings. You are looking into certain medical images and looking for certain patterns. There, machine learning is fair good because not all clinicians are expert in looking into finding out certain like certain particular clinical parameters into it. So to make sure that a machine can be more effective. Yeah, like a clinician can work for 8 hours and then he get tired, and then this can affect the performance. So in that scenario, if a machine learning is also there, it is not going to a kind of a replacement, but kind of an assistance where it highlights, okay, these are the regions which machine learning identified. Now, can you look into an can you say that yeah, it is correct or not? Yeah. So maybe looking into patterns, maybe generating patterns, recognition of these patterns, yeah, and then finally get into prediction. And then when it comes to prediction, again, it is completely a non-linear stochastic modeling based approach, yeah, where you have a lot of equations which is running around, looking into these parameters and then coming out with a value. It is not something like a machine is coming out with its own modeling. It's everywhere. We are feeding the data. We are just making the machine to understand it. That's what we are doing. So when we say machine learning, it's actually learning some task. Okay. So what it mean by task? What you have something called as a task where you want a performance, and to achieve that performance you require some experience. By using this TPE rule, machine understand or machine learns, and that's basically a learning algorithm approaches. For example, a task is to play checker. What is the performance metric is? Percentage of game won by the participant. And what is the experience? Over the period of time, the performance get improved, the task get improved. This is what we call it as a simple learning. The same thing which you are doing with machine also. You are giving an input, you are giving an output, you are expected set of solutions from it. You are running it down, looking for a particular parameter which is called performance metrics. That can be accuracy, precision, recall, F measures. Yeah. And then you look back, okay, I'm not getting this is in good way. Let's go back, change some more information so that it can perform well. Same with the example, for example, with like driving on a 4-lane highways using vision sensor. Yeah, average distance travel between before a human just error. That what is your performances, and you improve it down by what you are trying to do is like you're adding more experiences. What kind of experience? You're giving lot of sequence of images with command steering information. When you give these three things together, whatever the machine you are highlighting here, it's learning. In spite of machine, if you put a human there, again it will learn. And that's where the learning concept comes in picture. Okay, let me give you some examples of real implementation of AI in healthcare. Some of the real projects which is being running and which luckily I was being part of some. I will explain that what they are doing, what is AI roles there. That's what we will be looking into. So the first one, Fair for Health, it was green in symbol, you can see. Um, so the project was it's run between 17 countries in European Union. The idea was to benchmark set of sensors, to benchmark softwares, integrate it together so that they can identify certain parameters. And that parameters are being called as biomarkers for specific use case called cardiovascular disease. There have in these 17 countries, there are set of engineers, there are set of clinicians, and there is a company who is working on. What is their task is? So in the case of Fair for Health, we have multiple hospitals. All these hospitals have different patients. Yeah, we are collecting lot of information. Like from a hospital perspective, every visit of a patient, you have lot of information. You're storing it down in your system. What is the further outcome is? The patient is get treated, he got the solution, he is well gone. What is the further knowledge transfer here? Nothing is going on. So there, in fact, that's where the Fair for Health comes in. We are going to integrate all this information which is from different hospitals, come it together, binding that as a model, deploy it across the hospital so that when a new patient comes in, we are going to take the information, let's feed it to the model so that it can predict certain diseases. By that way, you can reduce the interaction of clinicians so that because by the model itself it is picking up, there are some particular disease it is going to have. Why don't we give it to an expert rather than going to the same process of general physician, then different diseases, and then finding a biomarker, then you go to okay expert, and then it's a long process. The challenge here is. So this is a simple process which I think that is what the clinician's knowledge is. You have a knowledge on looking into data and finding out who are the critical biomarkers, and then you get into the disease scenario, and then you take it down to the expert scenario, right? Here the problem is how you are going to integrate this data. biggest challenge. All hospitals, they have their own patient management system. They are different from different hospitals. Maybe a group of hospitals will have same company from which they are picking up this information. Think of scenario of MRI devices. You have Philips, you have Siemens, you have our own Indian companies are now also getting into picture. Their own data are completely different. How are you going to integrate such information together? Therefore, Health's task is to develop a web platform where the data will be fed from different hospitals, irrespective of whatever the standard it is being following. The idea is to transform these data into an open source standard, HL7. That was the standard which will be used. So, for example, there are data where there are a lot of NaN values will be there. There are a lot of columns which is free of, right? How you are transforming it into an open source scenario? First task. So, basic platform where first task is to transform the data into an open standard format. Now you have an open standard format. Now there comes the concept of AI or machine learning in, because now the data is common. In the case data is not common, then integrating such data itself is the biggest challenge. Yeah. So now the data is common. Now we have a simple model of cardiovascular disease. That was we took two cases. One is COPD cases. We took another one is CVD cases. Clinician doesn't understand what is going on in the web tool. We just tell them you just upload the data. And it is our task to develop a framework which automatically transforms the data into an open source scenario. Okay. Now there is another important issue comes. Then I'll come to that. Once you have an open standard data, you have a simple machine learning models by picking up the information. These are the biomarkers which the model has predicted, which we give it to the clinician. We ask them what it gave you as a model. Is it correct? The biomarkers are correct or not? What do you think? Is it fine or not? And there the value of performance comes in. We say that it is performing at 90%. Yeah. The clinician says no. There are a lot of errors there. Clinically, the algorithm is validated only 70%. So this is a huge difference. I'm talking that machine learning says 90%, clinician says it's only 70%. We have to go with clinician. And we have to identify what is the way by which we can achieve more and more better way. And the only solution for that is keep training your data more and more with more information. Reason, very simple, noise factors, collection of data, standard of data, size of data, these all are the factors. You take 5 minutes of data, you take 1 minute of data. The output should come in as a solution. So Pepper Health, 4 hospitals, 6 universities, 3 companies. We develop a complete platform. You can check down in your opinion. We highlighted one important problem here, and that's where the next project, Digi Vital Medicine, came in picture. The problem was data sharing. Each countries have their own standards. Each countries have their own laws of data sharing. Obviously, within India itself, if we take AIG Hospital and let's say some X more hospital, and when we want to combine this data together, right, as a model, will the hospital or the patient itself, who is the owner of the data, patient is the owner of data, will allow us to take this data, take it outside, do some analysis, take it a model, come it down. That was another challenge. So we have to tell to the patient that we are not pushing the data into the internet. It is still available with the hospital. If such scenario comes in, the problem is how we are defining a model, because then the model will become hospital specific. So what we did, there is something called as federated learning in the concept. We learn the model is remained in the hospital. The trained weights, which does not have any information of the patients, the trained weights are being pushed into the internet. So in case there is an attack happen on the weights itself, they cannot predict back who was the patient and what kind of data it was. So that is something I think, to the best of my knowledge, in an Indian scale, we don't have, and we have to come out with. That is something which is really important. There are still a lot of scopes because population is our strength, which we are not using. We have a lot of data which we can come out with that model. The second one is 5G Lego. This is another very interesting project where the reach of patients is a challenge to the hospital. The concept is there in India also. We have ambulances and mobile eye care services with hospital issues. But we are thinking of a little bigger device, something like when it comes to MRI sequence-based data, it's huge amount of data. When you add ECG-based information, other physiological sensing-based information, it's again become a big challenge, right? So what we can do it? So in that case, we thought of let's take the latest technology, which was now anymore not latest, which is the 5G technology. Let's put an MRI device in a truck, put physiological sensing in a truck, take it to the rural area. By that time, make sure that the 5G antennas are available. Push the ask patients to take the patients, collect the data, real-time streaming of the data via 5G technology to the hospital. We did this technology, we did this work, we published this paper also. The technology was really amazing. It provided us live streaming of MRI data. We used 3 Tesla machines basically. Now with 6G technology, we are talking already with the director of the also like why don't we come out with that, because now we are, I think IIT Hyderabad was very much expertise in 6G. Tesla machines are now, we have newspaper cuttings where it says that it's going to be cheaper. Why don't we combine these things together to come out with the information? Then it is more real approach of using technology for data system. So these are the 2 or like 3 different real project which is being running, which is using the application of AI here. Yeah. Now, when we say machine learning, as of now, it immediately get into what we call it as autonomous navigation. That is where we see that wow, machine learning is doing great. Why don't we take it to the hospital or clinical database perspective? So I thought of like explaining you what is an autonomous car or how it works. So once you understand how it works, then automatically you can understand the real challenge of data point here. So you can see it here, and this is a interesting autonomous car. If you look into an autonomous car, maybe I will take the pointer, I can't project it here. So if you see this autonomous car, it has multiple sensors. Okay? There are sensors called as LiDAR, camera, and yeah, LiDAR, radar, camera. I think these three sensors are enough to collect the information. So LiDAR is basically light emitting radar sensors. Yeah, it is continuously pointing off light wherever the cross section intersection is happening. That are the points. These points are being mapped together on the surface. That will give us what is there on the real time scenario. The next one is radar. So radar is sound wave technology where the sounds will go and will find out what are the blockages are available. Tesla came out with the idea of LiDAR because it is cheaper. But they also proved that LiDAR is not a self-sufficient algorithm or approach to go with autonomous driving. And that's where they get into visual camera based sensors. So in a vehicle now there are 4 different visual cameras. The task of these visual cameras is to pick up the images, stitch it down together, mark it down what is what, specifically target roads, lanes, drive on it. So in general, I have highlighted it here. So one of the important tasks of an autonomous navigation is path planning. Once you have path planning based approach, automatically the vehicle can be pushed. Because now we have electrical drivers, and you know that the moment you push a small electric current, the motor will start. So that's where it is connected to the wheel and the vehicle is moved, right? So path planning is an important challenge, and you can check it on. And this is one of the car which is very popular for autonomous navigation from Penn State University. So you can see there is a LiDAR sensor, there are stereo cameras, there are GPS, and there are object detection LiDAR sensors. Okay? So these all sensors are combined together to provide you an information. So now the question is how it is combining the information, or how from the image it is extracting the information. That's what we have to look into. This is a simple example. I tried to map you or to explain you how machine learning extract or pick up the information. You can see down in the bottom layer we have an image. Now our eyes can understand and say that it's a face. A machine has to take this information and tell that it's a face, right? So, what are the factors which you look to say that in an image it's a face? I need an answer from you. After 2 o'clock, it is little tiring. Nose, eyes, ears, contours. So, if I say nose, eyes, ear, or cheek, machine doesn't understand it. The reason is, if I say even for us to know what is a nose, it took at least an year to understand what is a nose is. Right? And we have a defined shape of nose. Anyone say me what is nose shape is? It's triangle. Similarly with ear, it is half circle. Right? Circular. Right? Same information we feed it to the machine, where we look into contours. And you can check it here at an initial level when we feed an image which is basically pixels. To the next level, the first information a machine learning pick up is edges or contours. So basically, if assuming that in this pixel, in this set of images of pixels, I have to tell that there is a vertical edge, then I have to give a simple matrix, a matrix of 3 cross 3, which is total 9 components. And in the center horizontal, in the center column, I will say 1, 1, 1, others I will say 0, 0, 0. Now if I multiply this value with any pixel, it will come out with one row, one column only. And that's where I say it's a vertical edge. Similarly, now I understand it that this is the way if I make vertical, I also know now how to make it horizontal. Similarly, how to make a diagonal, 180-degree diagonal. Now, what happens if the diagonal shifts a little up, shifts a little down, or if the vertex is only 2 columns? It's all different matrix which we call it as features. We impose on the images and we extract features, and that extracted features are which you can see it here at multiple line points. These are different lines which we are looking into. Next, and face will not have only contours. The face will have textures also, smoother vision. So we have another matrix which pick up the texture. Now you have texture, you have edges combined together, scale it up, you will get a face. Now the immediate question comes how? So if you see here, this is a simple neural network architecture, and you can see different nodes are there, and these all nodes are interconnected, talking to each other. So it's like one of the node to the other node telling that, hey, I found an edge here. Similarly, there are like 100 nodes are there. These 100 nodes will tell, okay, these are the edges, I found it. You take it to the next level. And now in next level, you have multiple edges. Okay. Now it just identify edges. How you are going to integrate it? Very simple rule. If this much is space, and if I give you half of this space, what do? You'll just identify half. If I short it down, smaller. Like this. We also take these images and subsample it down. Subsample to the minimus level. And from that minimus level, we extract edge, texture. Once we have subsample and obtain texture and edge, now we map back. The smaller segment join together to make bigger segment. The bigger segment will join together to make another bigger segment until you get a final image. And now you can see it here. From pixel to the edges with texture information, mapping it up, you have proper understanding of how a face looks like. And this is what exactly a machine learning does. In all this scenario, machine learning is not doing by itself. We are telling how an ear looks like, how an eyes looks like, how a face looks like, how a lips look like. That's why we have facial key points. The most refined facial key points are 512 key points. And that's what MediaPipe, it's a Google library being used in softwares like Facebook, Snapchat, or even in WhatsApp, where you have like rabbit nose, rabbit ears, face filters. These all are basically the key points. Now we highlight ear key point, pick up the ear key point, overlay with another image, the rabbit image or rabbit ears. That's what is happening. I hope it gives you little of understanding of how an image is being understood by the machine. Yeah. Now, so assuming that so far it is clear how edge and textures are being taken. Now let's look into the brain. How brain processes this information. Machine learning or simply the neural network is exactly the similar mapping of how our brain works. Our brains have neurons. We have a lot of sensors, eyes, nose and all. We collect information, pass it to the neurons and finally we pick up what is the final decision. In brain, we have something called as parse coding. What is parse coding? Out of 10 information, it's not necessarily you require all the 10 information. Only 3 information are enough to tell that the image is space or not. Right? Similarly, in machine learning also, we apply parse coding so that you are not extracting all the information, because then it is an extra load for the machine doing every computation every time. And that's where the way the brain is working on parse coding, giving importance that if in an image there is a nose and an ear, then it is a face. We are also instructing the information by telling that, see, here are the edges. Now, if this edges is complete, I'm giving the weightage as 0.8. If sorry, with this, if this is the edge, giving the weightage as 0.8 because that's a start. And if it is continuing until the end, then I'm giving the weightage 0.5. Combining all this thing together, I'm getting the information as this sample. The moment I get this sample, I will say it's a forest zone. That's what I was looking into here. That's what I'm trying to pick up here. So sparse coding is one thing which is very important in machine learning. Over the period we have lost it, but sparse coding is exactly like I think Professor Narasimhan was highlighting that if there is a blood pressure, ECG variations, PPG variations, which one you give the importance to highlight that which is the particular disease it was. The same thing is happening with the machine learning scenario. So this is a perfect example of how a simple neural network works, the deep learning based neural network works. So this is the human brain neurons responses. You can see exactly the same we are trying to predict here. What is being happening in the nucleus is what is the computation we are doing it here. We are giving inputs and we are expecting for a set of outputs defined by the activation function which tells the weights. So the same thing is happening here. You have dendrites to pick up the inputs, you have nucleus to process, you have axon to take the weightage of the information, and that is being taken to the next level. This is what exactly we are doing with deep learning scenario. Now, when we highlight, as I said that for facial information, we have 3 types of features: low level, middle level, and high level. And you can see that in low level, we are looking for edges, middle level, we are looking for textures, in high level, we are combining all these informations together to say that it's a face. Once you understand this logic, you have to take it to any of the different imaging scenario. Take it MRI, you take it CT, take it X-ray, you take it an ultrasound. We are doing basically an image processing with the perspective of learning in a machine learning algorithm. Yeah. Now there is a question comes: why suddenly deep learning or machine learning becomes so popular? Before, like I'm sure 2015 when I started, there was a buzzword of deep learning, and by 2016 it was like massive. Yeah, it's because of 3 factors. And these 3 factors contributed so much to the deep learning machine learning scenario that now anywhere you go, even a simple project like just kind of a structure, the startups are coming with that. We will introduce AI to it. I don't understand how they will introduce an AI to a structure also. Yeah. So only 3 things which make contribution to this advancement of machine learning is huge amount of data, huge set of hardwares which could capable enough to store this data as well as to process this data. And the software like toolboxes, PyTorch, approaches like model transfers. This all contributed together to tell that deep learning or machine learning exists. To your surprise, the first learning weights, like we assume that the deep learning or machine learning was started recently, 5 years back. It's not. The first learning mechanism was carried out in 1958. It was sustained until 1986. But over the period, because of huge amount of data, the computation gone so high that our machines are not capable enough to load all the data together. I remember my first computer which I bought was in 2007 with the memory RAM capacity of 32 MB. And now we are in a scenario where we can generate 62, 64 GB of a conventional laptop, right? So that exactly was the reason. Like you can perform multiple parallel computations together where you're feeding data continuously. It's almost like it's almost like the knowledge of each and every clinician who are sitting here taking their informations together to create a complete model. That's what is being going on in the future perspective. Okay, so let's get into a smaller more from the perspective of machine learning, because I thought the purpose I visited here was like first to tell what is a little of AI and machine learning, so that you can easily understand that not everywhere AI ML is required, and or maybe AI ML will not solve all the problems. It will solve some of the problems. So this is the basic classification of machine learning or deep learning scenario. It is being classified into two major parts: generative models, discriminative models. What you are seeing or what you are reading so far is example of discriminative models, where you take CNN, recurrent neural network, more popularly convolutional neural networks, you pick up the information, feed the label, kind of supervised learning to classify something. That's what you are doing so far. Now we are in the era where generative models are getting popular. That means you tell the information, the machine do lot of computation to generate the similar data. That's what is a generative model. Like ChatGPT or your DALI, these are all example of generative models. Now, how a generative model works? Sorry, but I'm using a very crude example. Assume that the student in a class 1, where we are teaching her or him how to subtract. He will easily pick up how to subtract. 8 minus 5, 8 in fingers, 5 reduced down, remaining 3 is the number. The problem comes when we teach her borrow. Because you have to tell her that you have to minus previous one, you have to add 1 here. That addition 1 is not 6 plus 1, it is like 1 and 6, such numbers. Okay. And how to improvise that borrowing technique by borrowing with subtraction? Practice, practice, practice. Keep learning, make mistake, practice. Right? Generative models are example of that. It starts with a Gaussian image, which is just set of pixels. We tell him make an edge. It will make an edge. It will tell us what is that. We will say that no, it's not an edge. Go back. Then again it make another correction. Tell us what. We make no, it is not what we expected. And this loop, if you make it 1 million times, you will definitely end up with a perfect line. And that's what is the generative AI or generative models are doing into it. So from the diagram, you can understand it like this is a simple restrictive Boltzmann machine. This is a recurrent neural network. Okay, and this is an example of a simple convolutional neural network. Now, I think I have talked a lot on like simple touch of the machine learning. Only last one slide, just want to highlight it. So what exactly we are doing with simple machine learning is like you have huge amount of information. This information you are compress it down, give it as an abstract representation, and that's what is this representation you are taking into further. And then you map it back so that you can really come back to the original image which we are looking into. And this is exactly the idea of autoencoders. It has an encoder where you get a lot of information, freeze it down to the most abstract information. What is the most abstract information? What happens if someone has hypertension? That means 120/80 is not looking 120/80. It is more, or in case of hypertension, lesser. Right? That is an abstract information, and that's what we try to pick up here by combining all the data together. An encoder, it's a reverse version of it. This is an example of a simple convolutional neural network, and you can see that by the small GIF, we are taking a lot of information to just take one value. We are taking this in every cycle. And when this cycle is complete, you have more abstract representation of your original input. Now, if I have, this is the first layer. if I do it with the second layer with the same convolution, again you are shrinking down the information so that you concisely say what is the face. It will have eyes, nose, and ears. That's what exactly is what machine learning is doing into it. Now, machine learning is basically classified into 4 different learning approaches. I will stop here. Yeah, of machine learning. Learning into 4 parts: supervised learning, semi-supervised learning, unsupervised learning, reinforcement learning. In supervised learning, keep in mind, in supervised learning, you feed the input, you feed the label together. You feed the input, you feed the ground truth together so that the machine come out with a better model. Okay. In semi-supervised, you feed the input, you feed partial ground truth, and the machine learns by itself on those images which it doesn't have a ground truth. What it mean by apple is a common word. Red apple, green apple. 2 different apples are there. What is different in both the cases? Colors. That's the only part which is different, right? In semi-supervised learning, you feed apple both red and green. You give labels of only red apple, so that the machine understand what is red apple is. Now it takes new knowledge how a green apple also looks like. That is what we do semi-supervised learning. And currently we are doing semi-supervised learning because we have already finished supervised learning with a lot of inputs and ground. Then is the next case which is called as unsupervised learning, where we don't feed information. Like we feed inputs, we don't give ground truth. It's the machine which has to come out by itself what is the ground truth is. Okay? It's like for example, the scenario is like, until now I have explained, when I feed an ECG data, I give the information of atrial fibrillation slots also. Right? Now I am just giving ECG data because machine has already understand what is an atrial fibrillation is. It has to come out with its own learning. The last one is reinforcement learning. Reinforcement learning, it's it's like you are keep on training a player to get better and better so that it will always perform well. Reinforcement learning is an example of like improvising the player continuously for a particular one task. Okay, the best case scenario is you are teaching your daughter, like I teach my daughter in the scenario of like subtraction. I tell her like you have to do this. She'll say why? If you do this, you'll get this chocolate, and then you improve it by giving more and more perks, and that's the way it gets trained on. That's a similar example of reinforcement learning. Why necessity? There is a when there is a necessity of machine learning. That is another important question. Machine learning is necessary when human can't explain their expertise. Human can't explain their expertise. Human expertise doesn't exist. Models cannot be customized, and models are like there are huge amount of data and you want to create the model. That is another thing. Because of short of time, I will jump to directly to a solution. There are a lot of slides. This is one of the example which we have. This is an algorithm we developed in our lab, and we are using it now. We are on the process, like we are already talking with Dr. Roop and technicians so that we can use it on a real-time scenario. It's from the perspective of like removing wires from the ICUs. No more hanging wires. That's the idea. So we are using camera as well as radar sensor. These are 2 non-contact sensors. Yeah, that means these sensors will pick up the information without touching the subject. We are trying to extract the cardiac health. So when I say cardiac health, it is more from the perspective of photoplethysmography, remote photoplethysmography. And if I have an RPPG information, I can extract heart rate variability, IBI, RI interval, you know it, right? So this is an algorithm which we developed in our lab. This is my student from masters, who is doing masters. The algorithm is take the facial information and then extract the remote PPG or photoplethysmogram and then give heart rate or beats per minute. We demo this algorithm in lab when Professor Reddy was there, Dr. Reddy was there. I was surprised when I was showing the demo. He went to the subject and he holded his heart rate and checking whether it was correct or not. I was really surprised. Yeah. Let me show you exam. Yeah, please. So you can see that this is with lowest resolution of camera. And science is simple, and we pick up the science. They are like how you see the things. It's because of reflection of light. There's something called the diffusion of light. There's a few smaller amount of light which diffuses, and we are looking into the regions of forehead and cheek region. We extract this region. We have RGB images. We only look into green channel informations. We only look into green channel informations. We average the intensity at these regions which is highlighted there. We will end up with per frame one value. Now we have multiple frames. It will end up with signals basically. Now we feed this signal into a Fourier transform so that we can look into the low frequency components, because in a minute heart beats 72 times, right? So in a second, how many beats? So that 2 or 3 hertz frequency is what we are looking into the Fourier transform, and that intensity value we are picking it back, mapping it down every frame for for 10 frames one value, and that's what is the PPG information which we are extracting from the facial information. We have already tested it. It is already working quite well. It's almost like we need just a smaller device of camera, map it somewhere, start picking the heart rate information. The longer perspective is just skip down. So this is another algorithm. This is another approach. You can see it now. We are looking into the human pose, body posture, because the couch which one of my colleagues is sitting, it is capacity ECG couch. And as I was highlighting, one of my goal of my lab is to go with unobtrusive or non-contact based sensing. So where we are deploying sensors in the couch, it's the subject who has to just sit and we are picking up the ECG information. We call it as capacity ECG information. One of the challenges we are facing now is huge noise. That's why we started looking into the pause. Right? Now, if we take this scenario, just moving. So this is a scenario of like an ICU scenario where we have a lot of cameras, per patient cameras we are deploying. Until now, we are just doing vital sign monitoring only. With this technology, where we have post monitoring, posture monitoring, as well as remote non-contact based heart rate monitoring also, we can easily map down like how good the quality of sleep the patient has had, how much time he was having some kind of movements, and by that way we can increase the quality of work life for those who are in the ICU scenario, because these information are in front of those who are in the ICUs. We are extending this work further with thermal cameras also, so that we can map continuous thermal information also, and also we are looking into the facial expressions so that we can map down symptoms like pain and other factors which is less expressed in this scenario. So these are certain works we are carrying out in our lab. I'll skip down. I'll just take 5 minutes more with just 2 more algorithms. So this is one algorithm which we developed in our lab, and it got published also. And this is exactly to the point of what Professor Narasimhan was saying, that most of these algorithms doesn't have the knowledge of context. Yeah. I'm sure that by this time now there are like 10,000 different algorithms on R wave detection or atrial fibrillation, right? But most of these algorithms are data dependent. Or whatever we take into the research papers and all, they are data dependent. Like they perform well for the set of data which is highlighted in the paper. And if we take that algorithm to a next level, to a next set of data, it fails. Or I have developed an algorithm which works for Siemens MRI devices, but if I take it to a Philips, though it's an MRI, so same set of information, but it doesn't perform well. And that exactly was the problem which we are facing. One of the very important another problem with these ECG based data was the noise. So most of these algorithms are noise incapable. So we developed this approach where we are transforming the signals into a symbolic patterns. We are looking into patterns of symbols generated. We are looking into co-occurrence of these patterns so that we can pick up atrial fibrillation. With the focus was this paper was continuously in contact with clinicians. We developed it. So clinicians was that don't give me a number telling that performance was this much, accuracy was this much. Because what it mean by it 99 performances? Can you give me a visual representation of a signal with normal ECG, a signal with an atrial fibrillation? A visual representation which like I can see it, I can wow, this is what I wanted. We end up with that approach also. We took the signal, we transformed into patterns, we look into co-occurrence matrix, we map down into heat patterns, and you can see that the left side from my side is left, right, is representing a normal ECG, whereas on the other side, the signals have atrial fibrillation, and you can see the pattern itself is showing completely different. Which, if we take it to a clinician, see, I have set of patterns which shows normal and atrial fibrillated ECG itself was good. Then comes the next question from the clinician. If I take this algorithm and test it on my device, will it work? That's a big problem because most of the algorithm is again device dependent. So we tested our algorithm with two different devices with different type of data. One was normal ECG, the other was capacitive ECG, and we could again able to map the patterns into the signal as normal as well as atrial fibrillation. Another scenario which we are doing is like transforming spaces into diagnostic space. I will just show like we are trying to transform the car into a diagnostic space because when you drive, you spend 20-30 minutes at least in Hyderabad, the traffic conditions. We are putting sensors into the car and we can pick up some physiological sensing information so that we can target certain chronic diseases, hypertension, diabetes. We can tell like it is popping down or you should go or look into their signal information. So when we are doing that, there are a lot of again challenges are there. I can give an example of how an AI is playing here. So when we take such information from the car, these informations are not coming like as a gold standard. They have a lot of noise. So we are using AI algorithms to identify those evaluable sequences and those non-evaluable sequences. And we are feeding only evaluable sequences to the processing part. So that's where like you can always have a filter, but it is not effective enough. We are taking an AI algorithm-based approach to look into the quality, signal quality. One more interesting paper which I will just show and then I will close it down. As I was saying that they are like 10,000 ROA detection algorithms. All algorithms say that they are really doing bad. So we came out with an algorithm. If algorithm's capability is like if from 10,000, if another one more algorithm added, the our algorithm will adapt to it. And it will keep on adding more and more algorithms rather than rejecting that. Right? And that's the way we tested our algorithm on not just one database, we tested our algorithm on 5 different databases with 5 different noise condition categories. And surprisingly, our algorithm did really good. And what we also tried it like when we combine multiple data together, whether the algorithm is performing. Like it is with three different databases. And then we added all the databases, will it be performing well? We also identified. And then what we did is like, can we add some other lead information? Will the model is able to pick up? That also we checked into it. And the algorithm is able to perform that. And that's where we added the value word called as generalizability of the algorithm. Domain generalization, basically. This is a very clear indicators like those locations where the false negative or false positives are left out by different algorithms. It was picked up by our algorithm, and then we also showed that XTEX is our algorithm. It can adapt with Kashif, which is 14 different algorithms, and it can adapt with Xiang also. By adding that also, it is not affecting individual performances. That's what we checked into. I think there are many more slides. I will end up with only one important question. I think Professor Dr. Rupi are already talking on that. Is the challenge on scales of emotions. So we have like these are different scales of emotions, which is being the ground truth or annotations. being used by the psychiatrists or psychologists to tell the emotional disturbances. In all the scales of emotions, discrete, dimensional, appraisal, and dynamic model, we actually ask to the patients what you felt, or by showing a video or an image, we ask what you felt, and he will say happy, sad, and these are the self-reported annotations which we take as an input for analysis. We don't have anything kind of thermometer like devices for detecting fever to pick up the mental health issues. So we are in the process of developing an instrument-based approach to quantify emotions, where the concept is simple. We are taking the facial expressions, we are adding not just macro expressions, we are adding micro expressions to it. Then facial expressions can be easily dumped or faked, but you cannot control your physiology. Now we already developed an algorithm which we can look into heart rate information non-contactly. We are now in the process of combining these three different types of data together so that we can pick up the real emotions in a real time for the that's where we are looking into the process of work. From this, I will stop. I think I have jumped many multiple locations rather than a streamlined one. More portion was given to AI and lesser was on the biomedical part because I know that you already know it.
Thank you, Dr. Narasimhan and Nagarajan, for two great talks. I think engineers will now go far ahead in diagnosing disease and giving precision medicine. But I think it's important now we should think of courses, integrated courses, right? That will give the most important or most precise precision medicine. So since we are running late of time, a few quick questions or comments from anyone? Machine learning stuff, right? You can.
In fact, some of the solutions, which are too expensive solutions, a generalist looks at it, he may have a simpler solution. It's not always true, but I'm just saying one of the important components in these discussions is to have a generalist who has a little more holistic idea, because system biology is becoming more and more important, and organs crosstalk. And it's not, they don't define as I'm nephron, I'm neuron alone, and there's a crosstalk. I think we need to have a very strong internist in the group, kind of guide through, because they have a deeper understanding of implications of crosstalk.
By next semester in my institute, I'm going to introduce a course called Network Physiology because now, as you said, there's nothing separated, all are interconnected. So we are now looking from a network perspective, how one impacts the others, and can we pick up the others one?
Thank you.
Okay, so if there are no more questions, we close this session for today and we again meet next Thursday. Thank you.